Okay, Perry, I think we're ready if you want to get started.
Ready to go? Sure. Okay. So good afternoon. Welcome to session number 3 of our CRCR study guide. Tonight's going to be a pretty robust evening. We got a lot of ground to cover, so we're going to move through the study guide relatively quickly. We'll try to highlight those areas which we feel will be on the test, or at least some variation thereof. But certainly, if anybody's got a question or a comment or wants us to go back, we'd be happy to do it. So we're not going to rush through it. So we'll just move along. We're going to start with course 1.8, volume to value, and then we'll move on. Christy, you are our page turner. You sit next to the pianist and turn the pages to them.
I am indeed. You should see
Okay.
the overview of the Affordable Care Act.
Yep, here we are. Okay, so this section deals with the Affordable Care Act and some of the components. Okay, as it was officially called, the Patient Protection and Affordable Care Act, which is known now as the ACA, was passed in 2010. And Christy, can you move your picture up a little bit, or can I do that? You're kind of like right in the middle of my, I got it, never mind, I did it. I'm moving you away. There you go. Okay. The ACA was designed to reform the healthcare system. It includes 4 distinct provisions: improving the quality of care, reform the healthcare delivery system, encourage pricing transparency, and address issues of waste, fraud, and abuse, which we will get into. Next slide, please. I have a delay on my end?
I'm at the improving quality of care slide.
Okay.
Kristen, is it delayed to you?
I have a delay, but I have another screen up, so as we move on.
It's a little bit of a delay on the screen share here. Yeah.
Okay, I got it. Okay, so improving the quality of care. Okay. What happened?
I'm just going to reshare it, Perry. 1 second.
Oh, okay. I'm sorry. Technical difficulties. I got nervous there.
It's good now, Christy.
We're all good?
Yep.
Okay, the quality of care is one of the major cost containments of the ACA. It has 4 components, one of which is reducing hospital readmissions, reducing hospital-acquired conditions, comprehensive joint replacement and cardiac services, and improving physician reporting. Did you move, Christy?
I did.
You did. Okay, for some reason I'm not catching up, so I'm going to follow along on another one. So we're on reforming the healthcare delivery system?
Yes.
Okay. All right. So another cost containment provision of the ACA is one is the establishment of ACOs and to develop new approaches to payment and delivery system through the Center for Medicare and Medicaid Innovation. Okay, it's taking me a little while here. So I think you're on the Medicaid Innovation slide?
I am.
Okay, that the Center for Medicare and Medicaid Innovation, they're charged to develop new models for delivery and payment of services. And if you so desire, this is their website. This is their page on the CMS website that you can go to.
Affordable care organizations.
Okay, ACOs. This is probably going to be a question on the exam. I know it's a question on the study guide. The ACOs were established. It is a delivery system consisting of physicians, hospitals, and other healthcare providers, and they work collaboratively to manage and coordinate the care for a specific patient population. Okay, their goal is the appropriateness of care, elimination of duplicate services, and the prevention of medical errors for a specific population. If they meet established benchmarks, ACO can share in any cost savings, depending on which model you're in. And for the purposes of Medicare, a qualifying ACO must have at least 5,000 beneficiaries. Okay, there are multiple ACOs, 4 of which are highlighted here, so we can touch on the first one. I assume you're on this slide, Christy, right?
Yes, more unaccountable care organization.
All right, I'm just trying to keep up with you. I'm a little got like that 3-second delay, like the debate. So the first ACO is the Medicare Shared Savings Program. Okay, and this ACO was designed to facilitate the coordination and cooperation among providers to improve care for Medicare fee-for-service beneficiaries. It's designed to increase the value of care by promoting accountability for the care of the beneficiaries, require coordinated care for all services, and encourage investment back into the infrastructure and redesigned care models.
Pioneer ACO?
Yep. The next ACO, Pioneer ACO, it's kind of like a precursor to a full ACO. If you are a healthcare organization that has some experience in coordination of care amongst a specific patient population, you can be designated as a Pioneer ACO. These groups, they can provide the coordination of care much more rapidly because they have the experience. They can participate in shared savings, and by being a Pioneer ACO, the first 2 years of the ACO, you have a higher level of shared savings, and in year 3, you can participate in a higher level of savings, and you can move into a more population-based model. The third ACO is the investment model, and it was designed for organizations participating as an ACO in a Medicare shared savings program. It's a model of a prepaid share savings, and it builds on the experience with the previous advance payment model. And what happens is the model will test the use of a prepaid share savings and encourages new ACOs to establish themselves in rural and underserved areas, and also to transition to arrangements with a greater financial risk. So they're getting paid more upfront in the hopes that you establish yourself in an underserved area. And the last model is efficiency designed around the care for those beneficiaries that are in an end-stage renal disease population.
Other
non-demonstration? Mm-hmm. Okay, so other pay performance programs, you have your reduction, okay, which is your hospital readmission deduction program. This was established in October of 2012, and hospitals were penalized if they had avoidable readmissions for patients experiencing heart attacks, heart failure, and pneumonia. In 2015, they expanded the readmission program to take into consideration COPD and total hips and total knees. The value-based program is the initiative that rewards hospitals with incentive payments based on how close they become to their best clinical practices and how well hospitals enhance the patient experience. So it was all around the patient experience. And then the third is reporting. It was physician quality reporting. And up until 2015, it provided financial incentives to physicians for reporting quality data. In 2015, the incentives went away, and physicians were actually penalized if they did not satisfactorily report quality data. We're on episode-based payment models?
We are.
We are, okay. So we have 4 examples of bundled payment models, if you will. Model 1 is the episode of care. Okay, so you have your inpatient stay, which is paid at a discounted rate based off your predetermined established rates. But under Model 1, your physicians and other suppliers are still paid under the Medicare fee-for-service schedule. Then we move on to Model 2. Model 2 is a retrospective bundled payment arrangement where at the end of the episode of care, excuse me, your expenditures are reconciled against what you're paid, but also the fee-for-service providers are still paid under the Model 3. So you're reconciling your hospital stay, and the physicians or other suppliers are still getting paid under the fee-for-service. In Model 3, it's an all-inclusive retrospective reconciliation for your inpatient stays and all of your fee-for-service. It is reconciled at the end of the episode of care, and you're also tacking on the back end your post-acute services, your long-term facilities, your rehabs, your skilled nursing facilities. So that's in Model 3. So it's all-inclusive. Your Model 4, okay, is a prospective bundled payment where you're paid up front for a specific episode of care, and during the episode of care, providers, physicians, hospitals, other practitioners, they're sending in no-pay claims to Medicare, and then there's a reconciliation process. A little more risk, but much more reward on the back end if you can manage your costs. And you are now on the joint replacement, Christy?
Comprehensive care for joint replacement.
Okay, all right. Another model was the comprehensive care for joint replacement model, and this was the first bundled payment model that they came up with because they were able, I guess, to tie it all together. It was more textbook than anything, but the bundled payment models going forward are usually fashioned after this joint replacement model. It's used as a baseline. Okay, I'm trying to catch up here. Okay, so under the pay performance initiatives, they have standardized quality measures, and they are a critical component of the CMS initiatives. The measures are tools that help us measure quality healthcare processes, outcomes, patient perceptions, organizational structure, and other systems associated with the ability to provide high quality care. So when they developed these standards, these quality measures, they brought into the fold many different organizations. And here's the list of them. You have hospital associations, the Joint Commission, Agency for Healthcare, consumer groups, major payers, healthcare purchasers, healthcare professionals, National Quality Forum. Oh, I'm ahead of you, Christy?
Yeah.
I'm on the example of quality measures.
I'm with you now.
Okay, all right. Okay, so examples of quality measures. There are 2 measures. Okay, measure 1 is the comprehensive joint replacement model that we spoke about. So they're using this as a baseline, and under that is when they're bringing in the total knee and the total hips and other cardiac-related quality measures. So they're using the outcomes as a baseline. They're measuring the complications occurred after the total hips and the total knees, and they usually have a span of 90 days, which begins at the day of admission, where they're monitoring those complications and the outcomes. And the following outcomes are considered complications, where you might have an acute myocardial infarction, pneumonia, sepsis, surgical site, and so on. So those are your complications around the quality measures. The second measure, or two of the second measures, I should say, goes back to our first night. One is the HCAP survey, okay, where they have 32 questions, 32 specific questions they will ask the patient regarding their stay. So they're using that as a quality measure. And the other is patient-reported outcomes, which is a voluntary submission of reported outcomes and any risk variable data associated with that particular case or episode of care. And right now they are in development or have developed ambulatory care measures. The National Committee of Quality Assurance to measure improvements in care. So our last slide brings us to a checkpoint. And what is the intended outcome of collaborations made through an ACO delivery system? So if we think back to the first couple of slides, it's actually to ensure the appropriateness of care, elimination of duplicate service, and prevention of medical errors for a population of patients. If you think of the ACO, it's always around a specific population of patients, population health, if you will. So answer number one, I believe. Well, see, it's on yours is different, Christy.
Yeah,
On yours is item 3.
Yep, the Q&As could be different. It's usually the same question. The answers are usually in a different order.
Yeah, I'm working.
Did we lose Perry?
Well, I think Kristen may have the next chapter anyway, so if we did, we could always check in with him later.
We'll just move on.
That's right. Sorry, Perry. We'll catch you up.
So my screen for some reason seems to be running a few seconds behind too, which is so strange because last week it didn't run 1 second behind. So figures.
And mine doesn't either. I don't know why. It's so strange.
Because I have to speak today, of course it will. So I have another computer in my office, so I'm using that. So we'll try to go through this relatively quickly. This module is basically about the financial statements and the impacts of the revenue cycle on it, and being able to kind of just know what the financial statements are. I say we because that's me, I'm an accountant. We're governed by the SEC, the FASB, and the GASB. SEC really doesn't impact us all that much because we are not for profit. However, some of us may have tax exempt bond offerings and things of that nature that SEC could play into that, but mostly it's GAAP and FASB, which guides how we do our financial statements. So each of the little buttons tells you about each of the different statements on here. The income statement, the balance sheet, and the cash flow are the 3 basic financial statements that an organization is going to produce likely on a monthly basis. Christy, if I go too far ahead, just let me know and I'll slow down compared to what my screen is showing for you.
You know, sometimes it's hard for me to figure out what I have to do in the guide to make it go forward. So
got it.
Yeah.
Okay. So the income statement is our summary of our profit and loss, or our revenues and expenses, and figuring out what our profit is. The balance sheet basically tells us where we stand at a particular point in time with our assets, cash, receivables, whatnot, and our liabilities, and what our net income is, and which could be our accumulated profits or loss. And then the cash flow is kind of how we spend our money. The accounting methods is the next screen. We're on an accrual basis of accounting, which means we are reporting our revenues and our expenses when they are earned or expended, not necessarily when the cash is outlaid. If you think to when we are treating patients, we have a patient that we discharge today, or we bill out today for services provided over the last couple of days, but we will likely not get paid for that patient until maybe 28, 30 to 40 days from now, but today is when we earned the revenue, so we're recording it now. And the supplies we utilized to service that patient, we would record now. So we have a matching of our revenue and our expenses. And then the fund accounting in not-for-profit finance that most of us are, that's our net assets and tracking the restrictions that could be associated with our net assets. And for the most part, that's going to be our fundraising related dollars, or in some instances, our grants where we can only use it for a specific purpose. We would call that temporarily restricted, or the new word is, I think it's donor restricted or something, restricted for purpose or something like that it's called. But the test will be based on the guide, not necessarily new accounting literature that, believe it or not, has just recently all come out in terms of how we account for certain things. So for our revenue, we have our gross revenue, which is our charges. That is basically our charge master. Our patients, no matter who their payer is, their room and board charge for a med-surg bed is going to be the same amount regardless of what type of service or what type of insurance payer they have. So that's gross charges. And it could be, it'll be different if they're in an ICU bed or what have you. And then net revenue is what do we expect to get paid for that charge or for that service. So our payers, we contract with them for what they were going to pay us for various services. So we'll get into it a little bit further down in the module, how we get from gross revenue to net revenue, but net revenue will be what we're expecting to collect from our payers. So determining net revenue, there are a few different methodologies for determining net revenue and the contractual allowances that bring us from our gross charges to our net revenue. So the historical adjustment for each health plan as a percentage of that health plan's gross charge revenue. So that's a method I use quite frequently on our cases that we call settled. So they're the cases that are zero, that we've been paid in full and we've adjusted off in full. And that's what we estimate our charge to our revenue to be. We come up with a percentage of that and we adjust down the gross charges based on that percentage. The impact of all health plan contracts and other self-pay adjustments that are posted at the time of billing. So that would be based off of the system generated allowances that our proration tables will have developed. Our Medicaid, most of us, Medicaid and Medicare, the charge structure is already built into our systems. So when the charges are developed at the time that the bill is generated, it brings it down to what that net revenue number should be. There's no reserve that's technically required on that receivable. Charity care is it's another allowance, but it's basically eliminating the revenue, and it's embedded in net revenue. There's no expense associated with that, but the concept is still the same. There, if you're 100% charity care, we're not generating any revenue from that patient, so the allowance equals the charge, and we have no revenue associated with it. Whereas the provision for bad debts is actually the expense associated with your net revenue. The way, actually, I described it this way at our CHFP session last week is charity care is the inability to pay. Bad debt is you can pay, you just choose not to. So the difference is one is an elimination of the revenue versus bad debt, which is the expense. Most of us actually report it up on top. It's net revenue, and then bad debt is reported in the same section. But you do actually report on your bad debt expense, not your contractual allowances. And then again, estimating what our contractual allowances could be on other items that aren't being brought down to the net already, again, would be based on historical percentages and things of that nature. And then this last tab is an example of what that would look like. So our gross charges are the 12.5 million for the month. We have our allowances that are recorded by the system at the time of billing. And then what we have estimated are additional allowances based on her historical look back, and as well as our reduction for charity care to bring us to what our net patient service revenue is, or what we expect to collect on a receivable, which is the 8.9 million. However, we've booked $1 million bad debt expense against that, so our net patient service revenue is the 7.9 million. So now offsetting the revenue side is the receivable side. They go hand in hand. That's the matching principle between what gets recorded on our income statement, also consequently gets recorded on our balance sheet until the time of actual collection. So and again, what reduces our gross receivable amount is in the same manner as what reduces our revenue amount. We have our contractual allowances, any self-pay adjustments, our bad debt reserves, charity care, and then other allowances that we might have to take into consideration. And then an example of the methodology for the allowances is here. We it's a little table on, I don't know if you clicked into it, Christy, but it's just a bigger version of that. You will, based on history and based on how your organization operates, you'll create the percentages based on your aging category. This one is very simply stated, for self-pay, we're going to reserve 25% for the 60 to 90 days from the first patient bill. Ratcheting up to anything over 120 days is going to be 100% reserved. And then a different methodology for Medicare or other payers, because they typically pay better than self-pay does. So you would be less aggressive in your reserve percentages for them. And how is the reserves noted on the balance sheet? You have your contractual allowance accounts, your bad debt reserve accounts, and your charity care accounts. So the contractual adjustments, again, it's the same manner as it would be on the income statement. You have your gross AR that gets recorded, and then any adjustments that are generated by the system would reduce that number. But then based on your payers that may be at gross or your self-pay population that you expect may convert into charity care or bad debt, you record reserve adjustments against those that receivable to come up with what your net realizable value, what you expect you're going to collect on the revenue. And then bad debt runs very similarly, but again, it's considered an expense, but it's net, it's a reduction of your net patient service revenue. Similarly, it's a reduction of your net patient accounts receivable. And the difference too is on your income statement, it's over a period of time. So generally we report in our income statement on a month-to-date basis and a year-to-date basis. And that's how your finance executives are going to report it to your board and your senior leadership. So it's over a period of time, where on the balance sheet, it's as of a point in time. So if we're doing our September 30th financial statements, we will be recording our September 1st to the 30th revenue, and likely January 1st to September 30th revenue. But our receivable is as of that point in time. This is what we expect to collect on all of that revenue that we have previously recorded. And then charity care, again, is the same concept of reducing our receivable. And it says it's presented as a provision for charity care services that reduces the gross revenue and the allowance for charity care, and therefore reduces the receivable. It is also included as a footnote in the financial statements. It gets reported in our footnotes. So in calculating the reserves, it's really, it's important to make sure that you calculate them as accurately as possible. Again, it's like when you're reporting, or your senior leadership is reporting the financial statements up through the board, the finance committee or the board, you want them to be as accurate as possible. There are many, many, many decisions that are made on your organization based on the results of your financial statements. So it's important to try to be as accurate as possible. That said, it is also, it would be important to, or it would be helpful if you over reserve your estimates rather than under reserve. Because if you're over reserving your estimates, you're reporting less than you anticipate, but you actually collect more. Versus if you were to under, I'm getting like feedback. I don't know. Did somebody come off mute? If you were to underestimate your reserves, you're not going to collect enough. So it looks like you are performing better than you normally would. But again, it's always better to be more conservative than it is to be aggressive, because of the fact that many decisions are made off of the financial statements, and you want them accurate for budgeting purposes and things of that nature. The contra accounts. In this guide, it's referring to the software that enables the provider to automatically reduce the account to the net realizable value. I think of it in a different terms. So if everyone could please put their phone on, or their systems on mute, that would be really helpful. So this is talking about the software that's available to allow for each patient's account to be brought down to what is expected to be collected at the time of billing, versus what is not posted as an allowance until the time of payment. So so the contra account, it's like the offset account to manage that information. Are there any questions, or did anything come up? Because I'm at the checkpoint for this. Which option is not a reserve amount on the provider's financial statement? Bad debts, contractual allowance accounts, charity care, contra account amounts. So the correct answer is contra account amounts, because those are that's not the account name, it's the amount that actually goes into it. So just keep in mind having your revenue recorded accurately. Know the difference between the gross charges, making sure that your gross revenue is accurate, and that you have the tools in place to determine the net revenue, which is net of the contractual allowances, and that you have the appropriate reserves in place, and that they're reported on your financial statements as the contractual allowances, bad debt, and charity care. So that was that session. Oh, sorry, you're a little bit ahead of me. Now it's showing up on time. So
I'll skip the last bullet point.
Oh, sorry. Okay. I'm not looking at my screen. Okay, so we're going to go over real quickly over the key performance indicators that you would use, or tools that you would use to do benchmarking, either within yourself as trend analysis, or amongst other organizations. They are a set standard in accounts receivable. They're used to measure collection and control of accounts. You would use them, again, like I said, to compare to your organization to other organizations, always within the same industry. And there can be variations, so you want to look at that and make sure that you have the agreed upon KPIs that makes sense to your organization. So the HFMA map keys are the 25 key performance indicators that they have that are divided into the 5 major groups. The patient access, pre-billing, claims, account resolution, and financial management. And I guess these were modified or redefined to better reflect current industry practices. And I don't know, let me see, let me turn. So this talks about just transparency of the keys. They're an industry standard. I think that they're a good tool. You know, HFMA does provide very good tools for us to be able to measure our performance and benchmark against. And I know they have those MAP awards too. And I think that this probably all lays into all that stuff. And then the third tab is are their key performance indicators, the one that they are providing benchmark tools against. And you can see there's quite a few, and it's pretty robust. Some of the ones that we're going to go into are in the next slide on measuring your accounts receivable. And there are definitely a multitude of different ways to go into measuring your accounts receivable. The first one, obviously, your days in AR, net days in AR. How long is it taking you on average to collect your receivable? And the study guide shows you a calculation for calculating that, and it's based on the calendar days. You have as I mentioned earlier, you have your receivable. It's at a particular point in time, but then you'll have your revenues over a period of time. So you're going to measure how long does it take you to turn over that revenue to collections in that particular point in time, and it does manage the operating efficiencies of your billing department. And how quickly they're collecting. So the lower the number, obviously, the better, because you're turning your revenue into cash on a much quicker basis. So the calculation, you have your net accounts receivable, what you expect to collect, and then the average days of net revenue. So if you're taking a 3-month average, which is what they're defining in here, typically it'll be over the year-to-date, whatever your financial statements are presenting. But if you do a 3-month average, if it's January, February, March, it's 31 days in January, 28 days in February, 31 days in March. The sum of those divided into your the revenue over that particular time is your revenue per day, and then how long does it take you to collect your receivable over that is what it's reporting out on. Then the AR aging analysis. There's a few. This tool is very handy and very important as well, is knowing what bucket your AR is aging out to. Your 30, 60, 90, even going farther out. How much is over 180 days? How much is over a year old? It's.
Hey, Kristen, I don't think I'm with you at all any longer.
You're not? Okay, I'm on AR aging analysis. Go. Oh, I missed all that. It didn't click me through there.
Okay. Okay.
Sorry.
No, it's okay. We got there in the answer.
Yeah. So I was on the first button, but that's okay. I think the important thing with your aging is you want to do it by date of service, not date of, yeah, so I clicked on that AR aging bar there, yeah. Not by bill date, although that is an important tool to know too. How long is it taking you to bill an account after it's been discharged? Because obviously that weighs into how long it takes you to collect. And then of course there are limitations on when you're allowed to actually submit a bill. Again, most of our systems actually do provide this information automatically. I'm on the importance of aging analysis, not sure. Because you can see some of your trends, or where you could be having difficulties with some of your payers, and where you might need to focus some of your time and attention on. So reasons for AR not being collected, there's a few different reasons why your AR would not be collected. And I think we spoke a lot in the beginning, and I think it comes up in later sessions as well. The importance of completing the pre-admission information and making sure that the patient's record is as complete as possible. It will and likely lead to delays in payment or denial of payment, or can lead to the bad debt. Not obtaining the time of service payments for co-pays, deductibles, and whatnot when you're registering the patient. If you're not collecting it at the time of payment, that is a self-pay piece. It is, I always refer to self-pay as no pay. Collecting that money becomes significantly more difficult once they walk out the door. Then, of course, if there's late charges on the account, the delay in medical record coding, insurance verification, all this information that delays our ability to bill for our services will lead to the potential for uncollectability. So the do's and don'ts when you're performing an AR aging analysis. It should be completed on a regular basis, and as well, it should be done for specific payers. Don't just look at it globally. Look at it by particular payers so that you can get that feel for what's going on. Tracking the number and dollars by specific payers, you can gain your insight to which ones, again, are repaying late, and which are paying appropriately, things of that nature. This one's good, especially for follow-up, sorting your AR in ascending, descending order. Obviously, in descending order, you can hit your big dollar accounts quickly and easily and really get that big influx of cash. But descending or ascending order will show you any issues that, quite frankly, you could have with your proration tables. If a payer, it could either be payers paying wrong, or your proration tables might not be set up correctly to appropriately value the receivable. I think I actually hit on those items already. Yeah, I think we're good there. And then some of the benchmarks. Every time I click on this link for the benchmarks, it brings me to an error. So I'm not sure what it says in there, but it's probably just some good information on what some of the benchmarks are.
Ooh, well, that's interesting because it's bringing me to error too. So we will let HFMA know about that.
Oh, okay. I thought it was me because I seem to be having all these issues. So, like, maybe it's just me. Yeah, actually, it just brought me completely out of the.
Oh, I see that. It did me too. Ooh.
So.
You're not alone, me too.
Okay, so. And it took me completely out. I got to log back into HFMA, I think.
Yikes. I'm going to stop sharing for a second.
Well, just while Christy and Kristen are getting back up, I just want to mention that, you know, it's very important on all of the important information that Kristen spoke about, that you have some understanding of how it's calculated, because there are various ways to calculate this. And, you know, sometimes, they make a change to the calculation or whatever, and it can move the numbers around. It's very important to be very consistent in when you're talking about days in AR and you're talking about days to collect, and you want to make sure that you understand the basics. You don't necessarily need to do it, like Kristen said, most of the time, you know, our systems can do it for us and everything, but you want to be sure that you understand the basics of it so that you know what you need to do to improve that. Like if it's taking you too long to get the bill out the door, maybe an issue with your charging. If it's taking you too long to get paid, maybe an issue with your payer. But you know, those basic concepts can really help you manage your revenue cycle.
Yes, definitely. And it is important to make sure that the data is complete and accurate as well, so that you know that you are getting good calculations. And always benchmark against yourself, because that's where you'll see any type of blip or anything going on operationally that you might need to address internally as soon as possible. So, okay, I think we're back online. So techniques for measuring accounts receivable. We have our discharge not final billed population. So this is the population of patients who have left the hospital, but we have not yet billed for them. And there's a few activities that, of course, we want to make sure that are done before we do submit that bill, making sure our charges are complete, that the medical record coding is complete, that the insurance verification activities are complete, and typically, in order to make sure that that is handled, there's this suspense period automatically embedded in the billing system that they say that, you know, we'll bill out 3 days after a patient discharges, so that there is time for the account to be coded and worked and things of that nature. And that's another good benchmark too, is, you know, days to bill, days to initial bill is it taking, if your policies you bill in 3 days of discharge, and your average number of days based on your indicator is 4 or 5, then you've got things that you need to work on in your organization and find out why it's taking so much longer. Because again, that also extends the day. Payers are supposed to pay in 28 days in New York State. Well, that starts when we bill it, not when the patient discharges. So if it's taking you 5, 7, 8 days to bill out that patient, it's going to take you that much longer to get the money in the door. I don't know if you had to go into the table there, the calendar pages table or whatever, but it's looking at, you know, what's your percentage of DNFB in relation to your accounts receivable. And again, the higher amount, the higher the percentage, and you should keep that number as reasonable as possible. I'm just looking to see if it gives a percentage in here, and I'm not seeing one, because I saw a couple of places. I always key into the percentages that they put into a study guide, because that might be one that is actually going to show up in the that could show up in the test.
Yeah, they have some percentages here, but they don't get that granular on the test with this.
Okay, good. That's why I'm kind of rushing through it, because I think this is probably not as well. KPIs probably a little bit more so than the financial statements. You should understand all of it, but I don't imagine it's the bulk of the exam. So final billed not submitted to pay. So these are cases that are held up in your claims scrubber for whatever reason. You definitely want to keep an eye on that, because it really should not be. It should be as close to 0 or 0 because of the technology and everything. If you've released it to the scrubber to be sent out to the various payers, you've done your legwork. But of course, some do bounce back. They do have their built-in technology as well. So you want to make sure you're working those as quickly as possible, so that you get your money. So obviously we're not a cash upfront business, but there is a cost to collect, and we clearly want to make sure that we're reviewing what it's costing us to collect our revenue. So in this example, it's saying that the expenses associated with collecting on a patient account is $150,000. They've collected $7 million. So that's a 2.1% cost to collect. And HFMA best practices, or they're based on 2016, it's 1.6 to 2.4. So this organization, their expenses are within reason for the amount that are being collected. And it was interesting, I think it was at Day's presentation last week, or one of the presenters at our Region 2 Institute last week was talking about when you have errors in your bill or there's follow-up that's required, the cost associated with each one of those steps is incrementally greater at each one of those steps. That drives this number up and costs the organization a lot of money. So it's definitely an area that you really want to pay attention to. And of course, garbage in, garbage out. The better we do up front and the better we collect on all of our information, the better this back end stuff works and flows through. Cash collection as a percentage of net revenue. So how much cash are we collecting based on the net revenue that we reported? Obviously, 100% is ideal, but the best practice for that is 95% or better. So if we have gross revenue of, in this example, 900,000, the allowance at the time of billing is 100,000. We've written off charity care of 35,000. We're expecting to collect $765,000. If we collect $765,000, we've collected 100% of our revenue. But if we only collect $740,000, then we've missed out on $25,000 that has eventually gotten written off to bad debt, and we're only collecting, I shouldn't say only, we're collecting 96.7%. It's within best practices, but we certainly want to be as close to 100 as we possibly can. And don't manage that through reserves. It's important that we actually collect the cash for the services that we're providing, and not just write it off to bad debt because of practices within the organization. And then point of service cash collection. We spoke about this a little bit earlier. This is our self-pay cash that we're collecting on co-pays, deductibles, co-insurances. And they're saying a percentage of cash collection up to 7 days after the occurrence of service is considered self-pay. Point of service cash collection, I don't know, I'm a little bit more harsher than that. It's what you collect the day they register and come into the hospital or the organization. So managing those percentages too as well, because you're not going to collect on everything, but they're saying that they've collected 450,000 on 2.9 million. That's 15.5% of the total self-pay collections. Managing that percentage is tricky, depends on your area and things of that nature, but you know, that's this 25 to 37% is a huge number. I'd love to see that in all of our organizations, but I think it's probably not really where any of us are at with our point of service cash collections, especially when a lot of us see our patients come in through the ER and you likely can't even talk to them until most of their services have already been provided.
Okay, so I don't necessarily like teaching to the test, but HFMA's definition of point of service cash being collected at or up to 7 days after, that is exactly that. That's HFMA's definition. I don't know that I've ever seen a question specifically on this, but that would be the answer you would select. I will tell you, you would probably want to check with your own organization on how they define point of service cash. I know in my shop, it's the cash you collect at the visit before the patient walks out the door. So it's money collected on the same day as the visit. So I hate teaching to the test in this sense, but that's just something for you guys to know. That definition is not the same definition from between all organizations.
Right. And that goes for anything in the exam. It is an HFMA exam based on at the national level and based on their criteria. So anything that is in here that is counterproductive to what you do in your job, know that it's based on this exam. It's not based on what you would do or what you feel your best practices are in your organization. So good point, Christy. Denials as a percentage of net revenue. Of course, you definitely want to pay close attention to your denials. You should have less than 2% of your claims should be denied upon first billing, but certainly track your denials to help reduce or mitigate them in the future. You definitely want to track the percentage of your denials, how many denials, and the dollar value of those, your top 10 reasons for denials, and what departments or locations those are in. Those are big areas for retraining and re-education, because denials are on you, not on the, well, most of the denials are on you, not on the payer. But if there's a systematic flaw in the design of your process, you're going to lose out on a lot of money. So managing and reviewing these denials and making sure that you're doing process redesign, and making sure that people are capturing what they need to in order to do the work. Because the other thing too is the denial could be something that the front end is doing wrong. Well, unless you tell them that they're doing it wrong, they're not going to know that they're doing it wrong. So it's important that that education happens. How many of you are reworked? What is the time lag between the receipt and the rebill? All these are very important to managing the flow of cash, as well as finding areas for improvement in your organization. Credit balances, the dollar value of credit balances in account at the account level divided by the 3-month daily average of total net patient service revenue is their definition of the days outstanding in credit balances, and should be benchmarked at less than 1% of the days outstanding in accounts receivable. So credit balances are very important to look at as well. Not all of them are money that has to be paid back. It's, again, another one of those areas that you want to look at to make sure that your proration tables are correct, that your charge structure could be correct, and what have you. So then I'm on checkpoint. I think I'm on checkpoint. It doesn't click through. What are KPIs? KPIs are the benchmarks which are used to compare key performance indicators in an organization to an agreed upon average or expected standard within the same industry. Oh shoot, I was wrong. I was right the first time. It changed the order. Oh, I'm sorry. It's key performance indicators which set standards for accounts receivable, AR, and provide a method for measuring the collection of the control. So I apologize for that. It was the bottom one the last time I did it, so I was trying to rush through it. And then here's our key points to remember. And then that's it. So that concludes the first chapter. I think we were going to go right into the second chapter, right?
We are.
So I think that's me. Can everybody hear me okay?
Mm-hmm.
All right, I have my thing on my computer here because I have a little bit of a lag too. So I'll look at both places. So we're going to jump into Unit 2, which is pre-service and financial care. So I'm going to go over the first couple sections. Christy will jump in where I start to stutter, and together we'll get through this. I'm sure most of you know or are more familiar with this section, so I'm going to go through it somewhat quickly. If you have questions, type them in the chat. Barbara will read them and we'll get them answered. So the first topic is patient types. So we're going to go through what each patient type is. There are 3 patient types: that's scheduled, unscheduled, and non-acute types of patients. So if you are following along in your guide, if you click on each one, there are 4 types of scheduled patients. The first one is a well, a patient's considered scheduled if the healthcare facility knows the patient's coming. So if you're a scheduled patient, they know ahead of time you're coming, and for the most part, everything that they need to do is done. They've looked at your insurance, they know what exactly devices or supplies that are needed, they know what room or equipment is necessary, and the professional staff is already available and ready for you. We all know that's not always the case, but that's what a scheduled patient is. So there are scheduled inpatients. I know it does seem kind of odd, but there are surgeries where you become an inpatient and you already know, could be a minor surgery or a major surgery, a hip replacement, open heart surgery. For the most part, those are scheduled, so they know you're coming. Sometimes obstetrician, I don't even know how to say that word. If you're having a baby, sometimes that's scheduled. I can't figure out how to say that.
Obstetrical.
There you go, obstetrical patients. So if you have a scheduled C-section, they're ready for you, so that's considered a scheduled inpatient. Sometimes direct admission patients can be considered scheduled if the physician calls ahead of time and schedules you. So if you go to your doctor and he says, okay, well, we're going to send you and get you admitted to the hospital, sometimes that is considered scheduled. The next is a scheduled outpatient. I think this is probably what we are most familiar with. This could be routine diagnostic. It could be pulmonary, interventional, cardiology, neurology, basically any sort of outpatient test or visit that you make an appointment for is considered a scheduled outpatient. Lab testing, pain management, ambulatory surgery, things like that. Most of the time, a health plan does require an authorization for these types of services, and we will learn more about those in the health plan section, which is 2.4. And then they're scheduled for recurring and serious patients. This is any type of ongoing therapy. It could be behavioral therapy, physical therapy, any type of recurring event that they will bill for every 30 days. So usually for 1 month, it's what they consider your series. If you go for physical therapy, occupational therapy, speech therapy, 1, 2, 3 times a week, whatever it may be, that's considered a scheduled recurring or series patients. It could, and these are like dialysis, chemo, radiation, anything where you're doing it for a long period of time and it's billed every 30 days. So if you click on the little thing there, it'll give you most of the services that are typically your recurring services, and this isn't everything, but it could be. All right, I'm gonna go to the next slide. Oh no, I forgot the non-acute types, sorry. Okay, so non-acute types, there are several health services available for people.
Christina, hold on 1 second.
Oh, sorry.
Yeah, no, it's the guide's not letting me advance until I click everything. So
did I missed? I don't know why. Oh, because I already went through my guide, so I'm not getting the.
Okay, so I think we should be up to types of patients unscheduled. Yep. Okay.
Right. Okay, I'm sorry. So I hit the wrong button on mine. Oh, no, go up one. Yeah, unscheduled right there. Okay, good. So unscheduled is inpatients or urgent care patients, outpatients or walk-in patients, emergency, observation, and newborns. If you click on the pictures, it'll give you the exact definition of what these are. So the emergency department is the most common source of an unscheduled admission. A patient goes to the ER and they're seeking care and you meet the criteria for admission, you therefore get admitted, but that's an unscheduled visit. The other types are direct or urgent patient, where the physician sends the patient directly to the hospital with a medical condition. And then once you're admitted, it's considered an urgent admission. So I don't know if you go to urgent care and they say, you know, you need to now go to the emergency room. So you go, you're admitted. That's what that is. Outpatients or walk-in patients. These are types of services like routine x-rays, lab.
Is there
What?
somebody I could pass control to so I could just take like a 5-minute break here?
Yeah, if you want to pass it to me, I could just share my screen and do it as a talk.
Yeah, you're the only one I don't see on the list.
Oh, that's odd. I'll just hit share my screen. Oh, I don't have a guide open on this one. All right, hold on. I don't have my guide open on this one, but I will do it while I talk, hopefully. All right. Do you want me to log into my guide, or is Kristen or Barbara, are you in yours?
Barbara, I just tried to pass you control. Can you?
I didn't have my Zoom. I didn't have it open because it jams my computer up.
Thank you, Barbara.
All right, Barbara, good? Okay. All right, let me move this out of the way. Okay, so I'm on unscheduled inpatients or unscheduled outpatients or walk-in patients. So if you just go back, it's the next box. So these are services like routine x-rays and lab tests. They're typically provided without the benefit of prior scheduling. So you're coming for an unscheduled routine outpatient service. Sometimes, I don't know about everybody's, like, you know, primary care, if you go for like your physical and they say, okay, go down to the lab and get your labs done, they may not have you on their schedule, or you have to go somewhere else for an x-ray. They don't need any form of pre-approval, so it's fine. Usually you just go, you get it done, and then you go back up to your doctor. So those are unscheduled outpatient or walk-in patients. If you go to emergency patients, unscheduled, all patients arriving in the emergency room are considered emergency patients and must be registered as an emergency patient type. Only patients treated in the ER are considered emergency patients. They could be discharged, admitted, bedded as an observation status, or transferred to another facility. This is the most common type of unscheduled. I would say emergency patients and newborns are probably the top two in unscheduled. If the patient requires inpatient services, the health plan may require more information once the patient is stabilized. And then I know, like, this is a national test, but most of the time, health plans will cover services regardless if the facility is contracted or not until a patient is stabilized. So if you go to an emergency room, the in and out of network benefits kind of goes out the window. Observation patients. So observation is used to evaluate patients for possible inpatient admission, to resolve a medical problem so the patient can be discharged, or for treatment that will last less than 24 hours, or complications following a surgery. It can't be used in lieu of a regular or routine recovery time. And observation provides services clearly separate from prolonged emergency room care. So if you remember back from Barbara's compliance, there, you know, the observation has a lot of rules following it, and it's not always appropriate. So it's very important that those are followed. And observation status is not appropriate as a substitute for inpatient admission or for continuous monitoring, and for medically stable patients who need testing or outpatient procedures. And it can't be used for patients waiting for a nursing home placement or convenience of the patient, the family, physician, or hospital, and routine preparation for procedures or routine recovery from another service.
You have to think of observation in the sense that you're watching or testing for something. So you're trying to monitor the patient. Just having them stay an extra couple of hours till they come out of anesthesia, that's not observing them. You know, I know it seems like an oxymoron, but you need to be doing testing, you need to be monitoring their condition to
Right.
qualify for observation.
And then the last one is unscheduled newborns. I think we kind of all know what that means. A baby delivered in the hospital is registered as a newborn. So that's what that is. They don't all pick when they want to come. And then we will go to non-acute types. So there are several health services available to patients which are not normally provided in an acute hospital setting. These include skilled nursing facilities, hospice care, home health services, clinic services, and durable medical equipment. So click the image. I'm sure some of you or most of you are familiar with each type, so I'm just going to go through them quickly. So skilled nursing facility is when they no longer meet criteria to be in-house for acute care, but still need an inpatient level of rehabilitation services. Most of the time it's for orthopedic surgery cases, or if the person just needs to get their strength back, things like that. Hospice care is intended to provide humane and compassionate care for patients who are in the last stages of an incurable disease. And Medicare certified hospice programs are required to provide nursing, pharmacy services, and physician services to the patient around the clock. Okay. Home health services. Home health services can cover a wide range of healthcare services, which can be given at a patient's home for an illness or an injury. So it could be skilled nursing, physical therapy, speech and language therapy, continued occupational therapy, etc. Medicare approved home health agencies provide medically necessary services to homebound patients requiring periodic skilled nursing or therapeutic care. There must be a physician order, and the patient must meet specific criteria in order for it to be covered by Medicare. And
one of the big criteria is they have to be homebound. Like they can't be going to the grocery store and then coming home and getting their home care. Okay, so that's a big, you know.
Right. Durable medical equipment, also known as DME. This is medical equipment designed as durable medical equipment, and it's intended to be used over and over again, usually by the patient or the caregiver, rather than being used once or a few times and then discarded. An example of DME is like wheelchairs, hospital beds, oxygen tanks, and it must be obtained from a Medicare approved supplier for Medicare to pay for Medicare recipients. It obviously, if you have a different type of insurance, it would depend on the patient's coverage, and that, you know, when we go into the insurance part of it, you would just know by looking at the eligibility what is covered and if the patient has to pay. So a clinic is a facility or part of one that is devoted to the diagnosis and treatment of outpatients. Many clinics are hospital-based and staffed by hospital-employed professional staff. So we're at the checkpoint. And the question that's going to come up, oops, sorry, Barbara.
No, sorry, Christine, I'm back.
Oh, you're back.
Yes, it just wasn't letting me get there, but we are there.
That's okay. We're just at the checkpoint, yeah. And this is a typical question that they will ask on the test, what patients are considered scheduled. So then you would select your answer, and that would be a recurring patient. Oh wait, I could probably be wrong.
Nope.
Observation. I answered, we have different things here on mine and yours.
But in this case, the recurring series patients, that would be like your physical therapy sessions and stuff. They're the ones who are typically scheduled.
Right. Number 1 on mine. Correct. All right. So
Christina, do we want to start 2.2?
I mean, it's very long.
I see that.
So I don't know if we want to just go over the first part, the scheduling instructions, or, core concepts, patient identification, and then move on.
Okay.
And then end it
start.
there.
Let's start it, and the guide will save us where we left off for next week.
We can just resume.
Mm-hmm.
All right, so we're going to move on to 2.2. If anyone has any questions, just type them in the chat, and then Barbara will make sure that she says it, and we'll get anything answered.
Well, unfortunately, when Christy gave me her screen, my chat box disappeared. So I don't know. Kristen, do you see the chat?
Barbara, I just stopped you from taking over, so you may have it back now.
It's back, so go ahead and chat with me.
All right, so we're going to go over the scheduling checklist. So if in your guide, you just click each box. So scheduling patients for service allows the provider to prepare for the patient's visit by reserving the time, obtaining information, securing equipment and resources such as room and staff. We all know we probably still have to wait anyway. If the patient does not go directly to the department, completed daily schedules are used by the service department and the patient arrival areas to complete final preparation. So you may have scheduled something, but you're reporting to a different area from where you scheduled it, but being that it's scheduled, they'll have all of your information. And then the components of the scheduling process is very important element of the patient-centric revenue cycle pre-service sector. The activities form the basis of the pre-registration and financial clearance. It's a mouthful. All right. Is it, I think there's only 3 click, right, Christy?
Yeah, I'm up to core concepts steps.
All right, okay, now we're on the same, it's just delayed. So if you click the pre-service section, you can explore the core concepts of the scheduling process. So we'll go with the pre-service. If you click on that, the core steps are patient identification, requested service, scheduling instructions, review and validation, patient reminders and arrival instructions, and order requirements. If you hit next, we'll review the concepts. So I'm not going to go and read every single one. I think we kind of all know exactly what the patient identification is, but this is the first important step in scheduling the process. You need to make sure that you've identified the patient.
And what Christina said there is a question I have seen, which is what is the first step in your registration process? And it's I think we talk about it later on, but it's super important to make sure you have properly identified your patient. You really want to look at that ID. You want to make sure you're looking at the patient with the right date of birth. Just to make sure you keep your medical records as clean as possible. You certainly don't want to chart information under the wrong account for somebody. So, but that is a question I have seen. The first step in the scheduling process is identifying your patient.
And then if you click on the critical information, it'll list what information must be collected and used. And it's, the patient's full name, date of birth, sex, social security number, And it's the patient's full legal name. So if my name's Christina, I want to tell them my name is Christina, not Chrissy, not Chris. It's what your actual legal name is. And then each patient is assigned a unique number. It's commonly called a medical record number, the master patient index number, or the corporate patient index number. Individual episodes of care are all linked to that medical record number. So if you do go to a medical group like Caremount or Nuvance or anywhere, if they pull you up by that medical record number, and all of your services and all of your records will all be linked to that. And it's very important to make sure everything is correct, because you don't want to duplicate and have one patient with multiple medical record numbers. The advantages of patient identification. When there's a service request, the scheduling staff must confirm the patient's unique identification record to ensure that he or she assesses the correct information. So obtaining and confirming accurate patient information is extremely important to avoid data errors such as duplicate medical record numbers, which we just spoke of. Placing the current episode of care with the wrong patient's medical record, that could result in life-threatening situations. If you have allergies or, you know, any sort of issue that may affect your life, and you have 2 Christy Spencers, you want to make sure you have the correct one up and you're putting the correct information in the correct record. And scheduling staff must be mindful that there are many people with the same name. Oh, I just did that. Who have changed their name, whether you're married, divorced, or use variations of your middle name, of your legal name.
One of the simplest questions to ask at registration is to say, have you ever been here before? And because patients will answer that like correctly. Yeah, I've been here. And then you can start to really look and find that person, and then you can start with, did you have a different name, you know, blah, blah, blah. But that's the key question, because if they've been there, if they've been to your facility before, they have an MPI number.
Right. And to Barbara's point, you want to ask them to tell you. Don't say, is your address still 197 Woodside Avenue? Because I may just say yes because I'm lazy and I don't feel like giving you my new address, or whatever the case is. Just say, you know, can you please verify your address today? Can you please verify your date of birth? Can you please verify this? Ask them the question versus telling them the information and them just saying yes or no. Okay. And then if you click on identification, it's just a list of other identifiers that you could ask the patient, and it could be part of their medical record. All right, so we'll go to requested service. A physician order is generated and becomes the basis for the request for service. So we click each button. So the first one is the contact for the request for service can come from the patient, the physician's office, or a service department in the healthcare facility. If the patient is scheduling the service, he or she is given a written physician order, or the physician's office electronically transmits or faxes written order to the scheduling department, and they're asked to call and schedule the service when it's convenient for the patient. The patient usually schedules services such as ultrasounds, mammograms, stress tests, therapies. The physician's office staff typically schedule surgery cases, catheterizations, and other invasive type procedures. Service departments can also initiate the scheduling process. This typically happens when a patient receives a diagnostic service and the result identifies the need for further services.
So there's not too many services a patient can just go seek and get on their own. One of the ones that comes to mind happens to be a flu shot, because you can go into just about any pharmacy right now and get your flu shot. But this is, and the reason I'm bringing this up is because this is a question that I've seen on the test But when there is a requested service, you need a physician order to generate it in order to start the basis, in order to have the basis for that service. So that is a key. That is a key right there. You need that order.
Right. An example would be a patient who has a chest x-ray with abnormal findings who now needs a CT scan. Do you think we should stop at this scheduling instructions?
I think we could get, okay, we could start, we'll pick up with scheduling instructions next Tuesday.
Okay. Yeah, I mean, I think we could get through this part rather quickly.
So does anybody have any questions? Hopefully you're all kind of going through the guide on your own in between weeks, because if you go to the guide and you have a question for something that you've reviewed, you know, write it down. We'll be happy to, you know, I mean, we won't go back, but we can certainly try to address it
Right.
to help you study as we go through this.
So, right. And to Barbara's point, I recently took a certification, another one, a study guide with Kristen and Christy. They taught it. And they did give some pretty good advice at the end. What you do every day, don't focus on. Focus on the stuff you're not very familiar with. Obviously go through the guide, but if you're in revenue cycle or you're in, you know, scheduling or whatever the case is, don't put a heavy focus on that. Focus on the areas you're more unfamiliar with. And then Christy, did you want to just talk, or should we send an email about election day? Because I know we're scheduled and I just know, like, I wasn't sure with the timing of that.
Yeah, I mean, I mentioned this to the team. If there's anybody on, if you want to speak up, now would be a great time. If you want to leave us a chat. We were just interested to know if people wanted to continue this class Tuesday night for election night, or if anybody had any strong feelings on it one way or the other. I do know some organizations have closed their admin offices on election day to allow their staff to vote and whatnot. So if anybody has any opinions, any thoughts on it, please, now would be a great time to voice them.
And if you don't want to say it in the group, you could send an email.
Yeah, this is Perry. I'll send the recording out again of tonight's session tomorrow or Thursday. Again, anybody that's not getting it because it's getting spam from their server, you can email me directly with an alternative email address and I'll get it to you. Also, it's obvious we're going to not cover all of the sessions in the predetermined time, so we'll probably add another session at the end of the schedule, which would be, looks like November 13th, somewhere thereabouts. So, you know, please try to schedule accordingly. If you can't make that extra session, we could probably do something offline, one-on-one. We're not against that, but we're obviously not going to stay within the time frame that we set up because the study guide is very robust this year. And if we do decide to schedule a session next Tuesday for election day, we find we have limited participation, maybe we can have an encore performance. So we won't leave you hanging.
Right.
All right,
Election day
everybody
is
be
not-
safe.
we have one more week, 2 weeks to election day.
Yeah, two more weeks of this.
Yeah.
God knows how long before we have results.
Yeah.
All right.
All
Thank
right,
you.
everybody get home
Everyone
safe.
have a great evening and a great week.
Thank
Bye-bye.
you.
Good night.
Good night.